Think Forward. Think Research Channel.
I am truly honored to be able to address you this evening and to share with you some of my interests in research and some of my approaches to managing and understanding fatigue. Why this talk? Well, first of all, we're at a university and we are here to share new knowledge. Second, I am hoping that we can offer an approach to gain a better understanding of fatigue and offer an alternative to the State of the Union address. What I will attempt to do this evening is to define fatigue and place it in a clinical context. I will also describe some of the research activities in which I and my Mason colleagues, those from Inova, the National Institutes of Health, and the National Naval Medical Center, with whom I am still in active collaboration, are engaged. And I'd like to present an overview of some treatment options to help better manage fatigue. So, what do we mean? Fatigue is fundamentally a nonspecific symptom that refers to a decrement in performance. It can either be physical or psychological, and this decrement can be objectively measured. Sometimes it's using a pencil and paper test. Sometimes it's looking at performance on a treadmill and measuring oxygen. Faculty in the Center for the Study of Chronic Illness and Disability are engaged in those kinds of activities. It usually is associated with a lack of energy, which can be objectively measured, and the perception of a lack of energy or motivation and associated distress. This can be quantified, but it usually requires a self-report, and therein lies a significant problem that we have had in trying to determine whether or not self-reports are objective or, the bad word, subjective. Regardless of how you classify it, the only way to learn how somebody is feeling is to ask them. So our best effort is to quantify it and to provide an instrument that is highly reliable and reproducible so that at least we are comfortable with the data that we are accumulating. Fatigue can be classified into two groups. One is normal, and this is what probably most people in this audience experience. Namely, it's associated with an identified cause. It's usually relieved when you stop the activity or rest or have a good night's sleep, and it's usually short-lived. You've run a marathon, you're exhausted, but you're exhilarated, and you rest and you feel energetic the next day. Or you have the flu, you've slept nonstop, but you've gotten over it in a few days, and our provost is happily very likely to follow this course. And if not, maybe he'll give me a call. There is something which will be the subject of my discussion tonight, which is called pathological fatigue. This is the one that really challenges us in the medical or clinical world. It usually lasts months or longer. It is not relieved by rest. One is very hard put on a number of occasions to try to identify the cause. It's difficult to treat. It interferes with daily life and causes distress. And it's frequently associated with a variety of mood changes, concentration problems, and changes in sleep pattern. And because of that, people will frequently think that these individuals are malingering, or don't have a real biological problem, or don't have an objective problem, and often it's just a difficult problem to treat. Going on with the classification scheme, which is important to understand, is that we are always looking for causes, and we have to look both in the periphery and in the central nervous system. And I am a mind-body monist. I don't believe in the duality of the mind and the body. There's too much crosstalk. They are highly related one to each other. And so whatever goes on in the periphery eventually gets communicated into the central server, and vice versa. What goes on here eventually gets communicated into the periphery. But for the reasons of classification, we've divided them into two groups. Peripheral fatigue is usually musculoskeletal or neuromusculoskeletal. Frequently it is exercise-induced, and it is usually a problem of energy utilization or a signal abnormality, like you don't have enough electrical signal going into the periphery. Central fatigue, on the other hand, is mediated by the central nervous system. It's usually exercise independent, and it's usually independent of disease severity. There are many people who will have significant central fatigue without necessarily having severe illness. It's often attributable to a dysregulation of the neuroendocrine system, and I will describe that in a later slide. So what are some of the parameters of a central fatigue problem? Well, failure of the nervous system to drive muscle. So for example, if somebody has a stroke and there's a cortical injury, the premotor cortex and the motor cortex may not be communicating signals that you have given it, I want to move my arm, in an effective way. Or the output from the motor cortex may be suboptimal. And so we have an abnormality in this part of the brain, and that translates to an interrupted signal going into the periphery through the spinal cord and into the end plate at the motor neuron. Now, usually, but not always, we have associated diseases with pathological fatigue. There are classically disease diagnoses that are very frequently associated with this amplification, if you will, of fatigue. In fact, fatigue may be the primary symptom or the seminal symptom of the disease itself. For example, rheumatic diseases, that is arthritis and lupus, are very frequently associated with fatigue, and often people will come in and present as the primary problem that of fatigue. It's also known that when the disease is more active, the symptom of fatigue is usually increased. Neurological diseases, and the classic for this is multiple sclerosis. One of the hallmarks of multiple sclerosis is profound fatigue. Not only weakness or spasticity, but fatigue is one of the hallmarks. Psychiatric disease, frequently associated with depression. Now, depression is not fatigue, but people who are depressed often experience fatigue, and it may be very profound. It may be both motoric, that is, it's difficult to get out of bed in the morning, or it may be profound psychological fatigue, difficulty actually getting through a mental process. Cancer is very frequently associated with fatigue, and that is going to be one of the bulk of the presentation this evening. I will speak about the data that we've collected in cancer-related fatigue. Then, of course, there's undetermined etiology, a fancy way of saying we haven't found the cause yet, but we certainly know that the syndrome exists. And chronic fatigue syndrome is one such example. Gulf War syndrome is another. That was first described when our veterans returned from the Gulf War. It was not so different from the chronic fatigue syndrome, and I will be defining this as my talk continues. Fibromyalgia and associated possible remote infections, such as Lyme disease, when you have an acute illness and you seem to get over the acute illness, but the fatigue persists. And so do some signs that you still may have either antibody reaction or something going on that hasn't completely cured, so to speak, the infection. Some of that is attributed to immune regulation or dysregulation. Infection and environmental hazards can certainly cause prolonged fatigue. And the metabolic and endocrine disorders, specifically, of course, thyroid disease and diabetes mellitus. So who is likely to have pathological fatigue? Well, Bell's work in nursing research in 1993 described a cohort of women who were most likely to have fatigue. They were elderly. They were women of low educational level. They probably had a chronic illness of fairly long duration, disrupted sleep, pain, depression, and a variety of comorbidities, some of which I will talk about in a short while, and a low functional status with low activity level and poor social support. I hope you are paying attention and haven't fallen asleep yet to this last point, because most people in the clinical world are very heavily invested in identifying a biological or a physiological abnormality. But the functional activity and your relative lack of physical activity and your poor social support contribute enormously to the presence or absence of developing pathological fatigue. The mechanisms are not entirely clear, and these are some of the things we're hoping to study in our center. So let's talk a little bit about muscle fatigue, which is an area that I'm pretty comfortable with. There's a difference between weakness and endurance, and just suffice it to say that abnormal muscle strength is what we call muscle weakness, and it's the inability to develop a force to perform a task, lift against gravity, punch somebody in the face, that sort of thing. Or abnormal muscle endurance. This is what we call true muscle fatigue. And the explanations for this are various. There may be inadequate electrical signaling, or the motor end plate has been destroyed, let's say with polio. The muscle tissue itself may be diminished, either through scarring or atrophy. The muscle tissue doesn't have sufficient energy to contract repeatedly over time, either because of a lack of blood flow, the heart may not be pumping well enough, oxygen uptake is diminished, or glucose is not taken up well by the mitochondrion, which is the energy factory, for a variety of reasons, one of which may be insulin resistance, and the other is an abnormality in the mitochondrion. These are fortunately rare diseases, but they do occur. And interestingly enough, they're associated certainly with fatigue and with muscle problems, but they're frequently associated with visual problems as well, such as Leader syndrome and retinitis pigmentosa of some sorts. Okay, this has the high fatigue logo on it, so please don't glaze over when you see it. This is an important slide. It's saying that the mitochondrion, which is our fundamental generator of ATP, which is the energy source that we use to power our muscles and to give our body the energy that we need. It has to have oxygen present in order to metabolize glucose and to put out this form of phosphate, which can be cleaved to generate the energy that you need to contract your muscle and to do other things metabolically in the body. So the mitochondrion requires an aerobic environment. It needs oxygen to perform its function of developing the energy source. Some very interesting work by Phil Leader at Harvard demonstrated that people with cancer, even if they don't have any existing disease that one can identify, essentially have moved more into anaerobic metabolism than aerobic metabolism. The body is somehow or another converted to a preferential state for doing things anaerobically, which is one of the reasons why many of us in the exercise world are so interested in introducing aerobic exercise for people with cancer, because we think it helps favor aerobic metabolism, which disadvantages any potential cancer tissue or cancer cells. That is all hypothetical. What is not hypothetical is the preference of cancer to the anaerobic state. So one mechanism by which fatigue may occur is going from a plump, good-looking muscle to a wasted, relatively atrophic muscle is in the presence of cytokines. Cytokines are cell products. The products of these cells are released when cells are signaled to go places, for example, where there are bacteria or where there is a sign of inflammation, and they release these as a way of, quote-unquote, controlling the local milieu better. The problem is they aren't frequently isolated to just exactly where the problem is. They're ubiquitous once they're released. And as a result of that, they may cause atrophy, wasting, and inflammation of muscle. We do have an antidote to that, which are these cytokines, IL-4, 10, 15, and 13, which turn out to be anti-inflammatory. So the body is in a pretty good balance in the normal state. If you have an infection, if you have a genetic disorder, if there are hyperimmune states, often it may favor this process. Rheumatoid arthritis is the classic example of that. Even before there is a high degree of erosion of bone and deformity, the muscle begins to atrophy, and that is in part a hallmark of an inflammatory process in which muscle becomes wasted as a result of its exposure to the inflammatory components. But in addition to what's going on locally, the contributors to muscle fatigue include the cardiovascular, central nervous system, the hormonal and the metabolic side of things, as well as energy sources and as control of glucose metabolism, environmental conditions, nutritional status, fitness level, and genetics. All relate to whether or not a muscle is going to be able to perform its necessary functions. So I just wanted to include a couple of slides just very quickly about the contribution of cardiopulmonary component to fatigue, or an antidote to fatigue, because I will later talk about some of the data that we have collected from our graft versus host disease patients, in which we are trying to understand whether or not there are relationships between pulmonary dysfunction and functional abnormalities. The answer to that is yes, but the question is, how are they related? So what are the mechanics of dysfunction? Decreased cardiac output, impaired heart rate variability, decreased lung perfusion, which is a very critical one for patients who have had bone marrow transplant and then may have a complication following that, and decreased muscular strength. This is the pathway that essentially leads to fatigue. The other, where you have, let's say, an overload of some sort with an increased filling pressure, is likely to give you breathlessness. This, where you have failure of muscle perfusion, is likely to be fatigue. And that's the kind of thing that we are more concerned about. The biochemistry of fatigue is also very important to understand, especially now when we are utilizing many new medications to try to control these things. For example, disorders of glucose metabolism, pretty obviously, may impair your ability to take glucose up from the intravascular volume, metabolize it, and produce ATP to generate the energy source that the body needs. So if you cannot take glucose into cells, and specifically into the cytosol around the mitochondrion, then you are not going to be able to generate ATP. You need insulin to do this, and to the degree that you have resistance to insulin, you will not be able to efficiently uptake glucose, and you will become hyperglycemic. Similarly, with fatty acids are good sources of energy, not as efficient as the glucose is by dint of the fact that it is metabolized in the mitochondrion. But nonetheless, these abnormalities are also potential contributors to fatigue. People with obesity are usually more fatigued than people who are not. This is a very busy slide, but I just wanted to point out that there is a form of liver disease in which there is fatty infiltration, not because of alcohol and not because of other toxins that we've been able to identify, but is associated with obesity. And the profile of these patients, compared to, let's say, somebody with hepatitis B or hepatitis C, shows how much more fatigue they have. And it's statistically significant. This is collaborative work that I have done with colleagues at the Inova Hospital, Dr. Zobair Younasi, and the first author, Amy Dan, is at the Cleveland Clinic. The biochemistry of fatigue, as I indicated in the muscle slide, does demonstrate that people who have increased levels of IL-6 and TNF-alpha, these are cytokines, they're products of cells, and a relative decrease in IL-10 are very likely to have fatigue states. They may be inflammatory, such as rheumatoid, or they may be cancer, and I will show you some data from our work demonstrating that. So that's a little overview of the periphery. Let's get to the central nervous system. We see the fatigue logo again. This is a complicated slide. It's trying to show you interactions among a variety of cross-talking methods within the central nervous system. So there is crosstalk between the brain and the body via hormones. They're ubiquitous. And they are very, very tightly regulated by something called the hypothalamic pituitary adrenal cortex axis. Signaling occurs when a variety of changes happen in the body. For example, if you're subject to a stressful event, the body is going to signal the brain. You will activate the hypothalamic pituitary axis, and the adrenal cortex will put out cortisol. That is a very necessary and important way of controlling symptomatology and putting stress situations at a lower level. In addition, the release of cortisol will downregulate, that means turn off, the production of cytokines. And as a result, it will decrease the amount of inflammation, which is why we often will use doses by mouth or parenterally of cortisone or its derivatives to control inflammatory diseases, such as vasculitis or rheumatoid arthritis. So that is one way that there is a lot of crosstalk within the body. When cortisol is well regulated, we are homeostatic. We are in very good shape. Cortisol rises in the morning, helps you get out of bed, get going, and then it drops off in the later evening, and then you go to sleep. If you are taking cortisol by mouth, it disrupts that cycle. So day might be night and night might be day, and sometimes that's what happens when you change time zones and you can't get to sleep because your diurnal variation has not caught up with your geographical variation, and as a result of that, things are somewhat topsy-turvy. So this is a very important component to our homeostatic mechanisms, and it does control the inflammatory processes which are so critical for protection, first-line protection, but also to regulate our sleep-wake cycles. So if one introduces a stressor into the body, it will signal the brain, it will activate the HPA axis, and it will stimulate the adrenal cortex to put out glucocorticoids, which then has an effect on white cells, it has an effect on bone, it has an effect on the lymph nodes, and it has an effect on muscle and the periphery as well. So nothing is really done in isolation, and the crosstalk is very important so that when certain levels are reached, the feedback mechanism will downregulate so that cortisol will shut off, or upregulate so it will be turned on to fight an invading army of some kind of stress, or downregulate when things have been returned to normal. The problem is that this regulation does not always go back to normal. And there are a variety of reasons for that. One is we have reset our thresholds. Number two, the genetics of the individual may be such that there is a relative insensitivity to cortisol or those mechanisms that turn it on and off. So it is a very complex relationship among all of these hormones. The catecholamines are there in a moment. They are not cell products. They are quickly released when you are subjected to either a stressful situation or an unusual situation. For example, they will excite smooth muscle and the lining of vessels and heart in order to give you that flight-fight reaction to a stressful situation. And if you're running the marathon, fortunately, it will inhibit your muscle function in the GI tract, so it will slow that down so that your blood can go to the periphery. But it also will increase the metabolism of glucose and fatty acids, so you can get the energy that you need pretty quickly. So we have a complex series of compounds which are secreted from the central nervous system in response to a variety of stresses and activities. Let me say a few moments about the fatigue syndromes, because we don't understand them very well, and we need to. We don't understand what starts them, and we're just beginning to get a little inkling about what might turn them off. The chronic fatigue syndrome was thought to be secondary to Epstein-Barr virus, the mononucleosis syndrome. It is a severe, sudden, disabling fatigue that lasts more than 6 months, and this is the definition developed by the CDC. And it includes the presence of at least 4 of the following 8 symptoms. And please listen to these because you will hear them repeated throughout several other syndromes so that they're clustering. There may be a little bit more or less of one or another, but these symptoms are highly repetitious in a number of yet-to-be-determined syndromes that have fatigue as their hallmark. Physical symptoms: headache, sore muscles, arthralgias, that means joint pains without true joint swelling, sore throat and lymph nodes, and problems with concentration and memory, sleep disruption, and severe exhaustion. By that we mean fatigue not precipitated by activity. Contrast that to fibromyalgia. Has many things in common, with the exception that here pain is one of the most important of the symptoms. Chronic, generalized, but localized into at least 11 of the following. So you must have pain in one or another of these areas, very specific, around the knees, around the elbows, and you can see the diagram as well as I can. That, in fact, is the hallmark of the diagnosis. But the fatigue is chronic and it's pathological, and sleep disruption is very typical. As a matter of fact, some people think it is a causal feature of fibromyalgia. But here, too, there is headache, dysphoria, abnormalities of memory and concentration, and chronic fatigue. Just a word about chronic Lyme disease. This is a very important illness, and it's very prevalent in this area because of ticks. It usually starts acutely, although many people are not aware of an acute illness. They might be aware that they have an illness when they see a very strange, large rash. It's a very characteristic large target lesion. It's an infection from Borrelia burgdorferi. It is often associated with flu-like syndrome. Flu is not common in the summer, so if you have flu in the summer, you should be suspicious that it is something other than true influenza. And it's associated with neuritis and this unusual rash. People will usually get over this with the proper antibiotic treatment, but a certain percentage, unfortunately, remain with symptoms, and they are frequently typical of what I've just described: myalgias, that's sore muscles, fatigue, arthritis or arthralgia, neurological problems, TMJ, that's the temporomandibular joint, and memory and cognitive problems. A lot of overlap among these, which is why many people feel that chronic fatigue syndrome and fibromyalgia may in fact be infection-related. And the question is, what kind of infection? It's been looked for, it's been discussed, it's been debated, it's been hotly contested. It's been proven pretty well that chronic fatigue syndrome is not chronic EB virus disease, because many people with it don't have that. Herpes virus has been mentioned, and a number of others. We are still looking for the causal factors for these diseases. And so what I am trying to point out here is that there's a lot of overlap among chronic fatigue syndrome, fibromyalgia, and depressive symptoms, which in fact have in common fatigue. And it really is important, I believe, for us to begin to deconstruct the fatigue component and understand what it is that has contributed to this symptom, which seems to be so prevalent in diseases which seem to be very, very different. And what are the features of depression? And I made a bold statement very early. It is not the same as fatigue. It is associated with sadness or despairing feelings, appetite changes, again, memory and concentration difficulties, headache, change in sleep patterns for sure, and decreased energy or a slowdown of your activities. So there are overlaps, but this is not the same. So why should we study fatigue? I tip my hat to Sir Edmund, who recently died. He did not take the helicopter up to Mount Everest. He and Tenzing Norgay climbed it together without oxygen, which is really quite remarkable. So we study fatigue, many of us do, and we're hoping to come up with some answers, because it's common, it's all around us. It's complex, it has many facets and a variety of causes and a wide range of impacts, and it's a major contributor to illness and disability. It's a huge challenge. This tells you a little bit about the prevalence. Of 100 people going to seek health care, about a third are going to identify fatigue as a concern. And a quarter of them will have it for more than 6 months, which is what we have defined as pathological fatigue. A quarter will leave with a firm medical diagnosis or psychiatric, but about 10% will leave without a diagnosis or a syndrome or an explanation. I got interested in this as a rehabilitation physician whose commitment is fundamentally to help preserve and restore function in my patients, to give them not only as long a life possible, but as good a life as possible. And came across a number of articles that suggested that fatigue is one of the best predictors of quality of life. So I figured this was a very good place to start. And in rehab, we're very interested in understanding the biological components, the physical performance components, and the experiential contributors. In the physical domain, the social and the psychological and cognitive. So this is fundamentally the framework in which I am working. I've had a good experience at the NIH studying people with cancer and being privileged to treat them. The NIH has a large population of cancer patients, and this is a very common problem. It's present this is the definition, it's present in people with cancer. The experiential side is that they feel that they have a lack of energy pretty much daily. This fatigue is not relieved with rest. It lasts more than a month. It has a negative impact on life activity, and it's usually chronic, relapsing, or persistent. It affects a very large number of people, but the series are very broad in terms of what percentage of patients with cancer will have fatigue. But the high-risk tumors tend to be the ones that I've listed, and the ones that I've become involved with have been the hematologic tumors, lymphoma, multiple myeloma, and leukemia, and breast. The former group is the group that receives bone marrow transplantation. It's one of the treatments of choice if patients fail the usual regimen of chemotherapies. It is clear that there's a higher incidence of symptoms during treatment, and it doesn't matter what kind of treatment you receive. And then it does taper off. But there are many who have fatigue before they even have their chemotherapy. So this is a measure of self-reported fatigue. It's one of the subscales of something called the short form 36, which is a self-report of a number of domains of activity in mental competency and physical competency. And this is a score which looks at vitality, how energetic people feel themselves. So we have patients with breast cancer at time 0. This is at the time of their diagnosis. This is collaborative work that I've done between the NIH and the National Naval Medical Center at the Breast Center at Navy. We have patients who have had a report of fatigue of less than 45. Low is bad and high is good. Less than 45 is considered moderate. Fatigue, clearly clinically relevant. And those who have more than a score of 45 on this vitality score, considered mild, or above 50 is considered normal. Norm is 50. So if you look at time 0, 63% of our patients had a fatigue score below 45. And at 1 year, 57% had a fatigue score below 45, suggesting, 1, it's prevalent, 2, it's not dependent upon treatment, and 3, it's persistent. So it's something that we really have to pay attention to. This summer, we worked on a project looking at these data in some more detail and found a very interesting finding, that in our patients who had moderate or severe fatigue, that is a score below 45, that the most significant correlation, and these are all women, by the way, is whether or not you had children. Now, I am not suggesting that a treatment for fatigue is either not to have children or to get rid of them. However, there is an important message here. Women are usually the caretaker of children, and there may be a variety of ways to make that better. Either get the children to help more taking care of themselves, not a bad idea, or to bring into the home other things that can help support those child care activities, especially during the phase-in phase of chemotherapy. So which illnesses actually contribute to fatigue in women with early-stage breast cancer? And there are no surprises here. Hypertension, diabetes, heart disease, arthritis, and depression are all more statistically significantly associated with fatigue in a cohort of almost 2,000 women with breast cancer. And this is 5 years after the diagnosis. If you look at our patients who have hematologic cancers following bone marrow transplant, and all of the patients I will report on who have had hematologic cancers, in fact, do have bone marrow transplantation, we will see that males or females, they have a diminished grip strength. Therefore, they are weak. They have a diminished ability to walk the distance that a normal person would walk in the time that the normal person would walk. About 30% have predicted. Most people report that they have a moderate level of disability, and their vitality scores are below 50. You notice that women have a lower score than men, and that has been very characteristic of all the literature. We've looked at the relationship between a self-report for this population of patients and a variety of physical measures. So I report that I'm fatigued, and it turns out I've got a low grip strength, and I've got a slow walk time, and I am not doing as much as the person who is not reporting fatigue. And if I try to figure out which of the biological measures are most likely to be related, it's what their lung function looks like. So if they have an abnormality of diffusion capacity in the lung, they are more likely to have decreased strength, abnormal walk time, and a low performance measure, self-report. These findings were reported at the American Society for Clinical Oncology in June of this year. If one looks at the correlations between diffusing capacity of the lung, you can see, as I showed in the previous slide, that there is diminished grip strength, but there are also a host of biological abnormalities that are also associated. And it seems like we may have a biological profile of people who are likely to have problems with grip strength, walk time, and their performance levels. And it may be this biological profile. We haven't tested that yet, but this slide suggests that it's not only about physical parameters, but there are contributors from the biological side. If we look at their cytokine profile, we also find statistically significant correlations between people who have this clinical syndrome and high levels of IL-6, high levels of the interleukin-10 receptor blocker, and our TNF receptor 1, so that it looks like there is a cytokine profile associated with people who have abnormalities associated with bone marrow transplant. If we now look at the relationship between the cytokine abnormality and the physical parameters, if you have a high level of TNF receptor, that means you've expressed it, so TNF levels are high, which is one of those cytokines of inflammation. You have a lower grip strength, a lower walk time, and a lower vitality score. So we believe that that should be part of the biological profile as well, namely looking at these markers of inflammation. So what have we found? In cancer-related fatigue, about 2/3 of our cancer patients, and even before treatment in the breast cancer group, are going to be fatigued. There are biological abnormalities, there are performance-based abnormalities, and there are perceived problems with low energy and their ability to perform. So what can we do? Number 1 and 2 on the list is to control any of the covariates. In other words, if you have any of these other processes going on, they should be treated. The likelihood of improving the symptom of fatigue is very high. You also need to go one step further and begin to look at other contributing factors, such as the level of fitness, nutritional status, medication, whether or not there's concomitant pain, emotional or physiological stress, and what is the sleep pattern like. So what can we do? Well, we have to absorb what we are learning about in the media all the time. We have to go to alternatives. In the car model, we have flex fuels. So you can tank up on gasoline, or you can tank up on the leftovers from frying our potatoes at McDonald's. The issue here, and I'm not trying to be funny, is that we have to start looking at a variety of ways that we get our energy. We tend to gravitate towards high carbohydrate and high fat. And perhaps what we need to do is start thinking of alternative fuels, which is more protein, less carbohydrate. So we have to think of changing our driving habits or changing our consuming habits. For the rehabilitation specialist, you know, I've got a hammer, so the whole world looks like a nail. For me, the interventions are frequently around introducing exercise. Now, my colleague, Dr. Allie Weinstein, keeps telling me, how are we going to get them to keep doing it? That's her job, not mine. I want to know whether or not this works. And my other colleague, Dr. Randall Keyser, is going to tell me exactly what I'm doing when I get them to do the exercise. So we've got all the bases covered. We just need to get it done. So exercise to promote fitness and avoid disuse. We have a variety of techniques. And the results have been excellent. They have been demonstrated time and time again that we can increase our oxygen consumption, we can lower our heart rate, we can improve our function, we can increase our lean body mass, decrease our symptoms, and increase our internal locus of control and feel like we're taking charge. We are in control. So exercise is an excellent contribution to dealing with fatigue. When one of the students interviewed me for an article in Broadside, the student magazine, I said to her, "You know, we don't treat fatigue with rest." She said, "What?" And that is the point. Acute fatigue following the marathon needs to be treated with rest. But pathological fatigue should not be treated with rest. It should be treated with what I've begun to show you. We need to control the source of energy, we need to control the exercise patterns and the sleep-wake cycle and treat all the comorbidities. So we know that we can make you better by improving your exercise tolerance and fitness. And another way to do it is through group exercise training. That includes fitness training, strength training. It improves quality of life. It improves affect. It usually decreases distress, except when you're on the treadmill or the bicycle. So in fact, we have ways that we can approach this. And I do want to make a pitch for not necessarily having to think of it as high intensity. You don't need to do a high intensity program in order to get the benefits. For example, activity to maintain function or prevent deconditioning goes a long way. And so we're looking at a variety of models of interventions, not only the ones that target a very high percentage of your VO2 max in order to get you tuned up and fit. And there are a variety of, shall we say, out there interesting ideas to regenerate muscle, everything from doping, which I think we all know too much about, stem cell transplants, which can replace fibrotic and scarred muscles, ways of reducing stress, likely to have a positive effect on muscle as you drop the cortisol level, using anti-inflammatory cytokines, and fish oil. Omega-3s seem to be very good for helping to develop muscle bulk. Just a final word about exercise and weight gain in breast cancer patients. Weight gain in breast cancer patients is not a good thing. It is associated with a higher incidence of recurrence of the tumor and death from that recurrence. And so we are trying to push exercise for our patients who are undergoing treatment for breast cancer and for the rest of their lives. And in fact, the secondary benefit is that women who do this experience less fatigue. So, welcome to Dr. Gerber's fueling station. We have a way of treating your fatigue, and it may be medication to control your illnesses, food with a healthy eating style, and of course walking up the food pyramid, physical measures such as strengthening or participating in team sports, sometimes even get to the Final Four, psychological support, stress reduction. People with Tai Chi and yoga seem to have great benefit, and some of the newer methodologies for replacing tissue that may have undergone abnormal stresses, and education, education, education. So it takes a village to do research. This is not a political statement, but the credit goes to Senator Clinton for writing this book. And special thanks to Dean Shirley Travis and all of my collaborators at the various institutions. We're all climbing up the same mountain. Thank you so much for your attention.